I hope I'm audible. Am I audible?
Yes.
Okay. This is Dr. Khizra Maqbool, Fellow Infectious Diseases from Shifa, and I welcome you all in the first ID CPC arranged by Shifa International. I hope it will be a good learning experience for every one of us. So this is a case of a 30-year-old male patient. He is from Malakand KPK division. He's married, and we took history. He had no high-risk behavior. He had no known addictions, not on any regular medication, and had no prior comorbids, no known drug allergies. And he was a shopkeeper by profession. So he presented to us in the emergency on 16th of November with chief complaint of headache, which was from almost 2 weeks, since 1st of November. And he reported it to be very severe, persistent, mostly located in the bilateral temporal region. And he denied any early morning worsening associated with it. However, he gave history of vomiting episodes, photophobia, and phonophobia as well. So upon systemic review, there was no relevant history of any preceding fever or flu-like illness, or at the time of presentation as well. There was no altered behavior, irritability, altered sensorium, any fever, any focal body weakness, fit-like activity, sphincters were intact. Also, there was no history of any change in vision, discharge from the nose, ear, or any recent dental problem. On further inquiry, there was no skin rash, lumps in the body, change in the weight, any respiratory or abdominal symptom. He had no recent or past history of tuberculosis. There was no exposure to any pets and cattle at his location where he lived, and he had no recent travel history as well. So we inquired further, and he told he had a road traffic accident back in 2016, which was not worked up at that time, but he had a lingering chronic low back pain since then, which required painkillers. And recently he underwent a procedure, laminectomy, at L4, L5 level in October 2024 in a healthcare facility in Peshawar. And according to him, there was no immediate complications linked with it, and he was discharged simply on painkillers. And record of this surgical procedure was not available with us. This was only the verbal information. Next slide. On examination, he had stable vitals, blood pressure of 180 by 88, a regular pulse. He was afebrile, not requiring oxygen at room air, and general physical examination was also okay, alert, conscious, cooperative, oriented, no physical finding over the body. Except for the surgical side, he had mild tenderness on pressing, but there was no redness over it and no active discharge. The neurological examination, it was also okay. He was oriented, following. The cranial nerves were grossly okay. The only significant finding on the examination was neck stiffness. And the other systems, cardiovascular, respiratory, and GIT, they were also undermarked. So I would raise question to all of you, especially the fellows, based on this short history, this 30-year-old male with headache and with no fever and neck stiffness, with a 2 weeks back, the symptoms are from 2 weeks, and he had a recent surgery in October. So what do you think, what will we think at this point? Anyone, please?
Assalamu alaikum. This is Dr. Seba Shaneem from AKUH, and as per this history, my differentials would be a possibility of vertebral osteomyelitis, could be spondylodiscitis, only discitis, could secondary to any gram-positive, specifically MRSA organisms, Strep species. We should also rule out, although there was no history of zoonotic exposure or any the specific history pertaining to that. Brucellosis, spondylodiscitis would also be my differential.
Thank you for your
And
contribution.
sorry, not to mention, last but not the least, the would be meningitis likely.
Anyone else? So the differential which comes to our mind on just the basis of this history, meningeal irritation without fever can be community onset meningitis, subacute, chronic. It can be post-surgical meningitis. He had hospital exposure. He had surgery. It can be aseptic meningitis as well because he had long history of NSAIDs intake and recent history of multiple painkillers intake as well. So next in line can be secondary headache post laminectomy procedure. There can be, though there was no active discharge from the site, but there can be a micro leak, CSF leak, intracranial hypertension can cause. Lower down the list, we will keep the migraine, though there was no prior history, but it can also cause headache with no fever and neck stiffness as well. Among the intracranial pathology, raised intracranial pressure, cerebral venous sinus thrombosis in this age, and can be intracranial lesion as well. So this was broadly going through our mind at that time. The initial investigation revealed leukocytosis in the blood CT report 16,000, with it was predominantly neutrophilic. Hemoglobin platelets are okay, but CRP was 9.8. Serum electrolytes, renal function test, and LFTs were okay. So we this with imaging. Can anyone comment on this imaging? Grossly, you can see.
How about one of the other centers?
What is the question? What about other centers? Sir is asking कि other centers से fellowship contribute करें और पता है. Story और बाकी centers story है ना? जी सही. Joining fellows? Any covers?
So we have combined all the four brain images into one. The first one with the red mark is the T1. Second one with the green is the T1 with contrast. And then there is T2 and flare image. So there is not a very, I would say, pronounced finding, but very subtle changes in it. The first mark of the red and green arrows, which you can see, it shows enhancement. So this was at the level of the first part of MCA. There is this enhancement, small nodular lesion, it was commented, and you can also appreciate on the T1 with contrast, the one with the green arrow, meningeal enhancement. Only the slight white appearing parts in it. In the T2, it was also seen air in the ventricles, ventricular horns. So pneumocephalus was another finding. So the reporting was accentuated meningeal enhancement in the bilateral cerebral hemispheres. and a small linear nodule enhancing focus along the proximal M1 segment of right MCA, which I just showed with the arrow, and small amount of air within the frontal horn of bilateral ventricles. Since neurosurgery was also on board, so they advised MRI lumbar spine with contrast as well. Anyone quickly, if you can comment on it.
Even I can see something, so please. It's pretty obvious. Though I don't know what it is. Any comments from fellows?
Which areas scan is this one? The first one.
So even if you cannot interpret it, this is a scan of the lumbar spine. So at the level of L4 and L5, you can grossly see there's some destructive changes, right? The lower three arrows. And there is air inside as well, the black appearing part. One finding is this. Second, if you trace it upwards, the green arrows, which are going upwards, they are pointing towards the white area highlighted, which is more prominent in the T1 with contrast, the arrows area. This is the enhancement, meningeal enhancement over the lumbar spine. So when we traced it, it was so enhancement was also present till the thoracic spine level, though very subtle in the images, but it was also in the thoracic spine imaging level. So we discussed it with the radiologist. There was a small loculated fluid and multiple air locules in the lumbar spine area at L4, L5, and the post-surgical changes. But this collection was very small, so not documented in volume. Diffuse meningeal enhancement at the level of L4 and 5, ascending to the conus medullaris. So we also discussed with the radiologist the first lesion that we looked in the MRI brain over the MCA area. There was no diffusion restriction, which ruled out PN abscess. So the prominent finding in the imaging is meningeal enhancement. This was the first CSF analysis at the presentation. It was turbid in appearance with WBCs of 2,129, predominant neutrophilic, and glucose 15.10, protein 144. Now combining the history, we just discussed the imaging and the CSF analysis. Anyone quickly please comment? What could be the differential speed?
Could be spinal abscess with ascending subacute bacterial meningitis.
Okay, that's good. Anyone else?
Any other comments?
Anyone from any other centers? Okay, we will show you all list of differential, and if you want to add anyone, you can. So we kept the post-operative secondary meningitis on top. Probable the primary source, the spinal and the paraspinal infection. Possible epidural infection post-surgery. There can be non-surgical disseminated meningitis as well. Bacterial on top, nosocomial TB, fungal, lower down the list. There is a possibility, for the sake of discussion, for a post-operative CSF leak, which can present with a spinal paraspinal infection and the presence of air over the lumbar spinal area and in the ventricles as well, the pneumocathars. So if we look into the etiology of this, the gram-positive by staph, staph and enterococcus are the common ones. Gram-negative rods can be Pseudomonas, which is also the common in nosocomial setting. Then they can be enteroventurations. Anaerobic bacteria, why do we think of it? Because of the loculated fluid collection at the spinal level. And it can be polymicrobial as well, due to being the history of him being post-operative, so it can be contamination. Very less commonly was in our mind, and it can be fungal or mycobacterial. So, is everyone on board with us till now?
Any other comments?
Okay. The CSF microbiology. Direct gram stain was negative. MTB gene expert came out to be negative. HSV PCR came negative. And at this time, CSF culture was obviously awaited. Hospital admission was from 16 to 19 of November. In the emergency, ceftriaxone and vancomycin were empirically initiated. ID was taken on board on 18th of November. We stopped the ceftriaxone. We continued with vancomycin, and we started with meropenem. Neurosurgery was also on board, and we discussed regarding the collection at the lumbar spinal level with neurosurgeons and the intervention radiologists as well. It was very small and not drainable, hence it not touched. This patient was discharged home in stable condition on vancomycin and meropenem. So the first visit was on 26th of November, and we called the patient at this time because we received a microbiological alert that there was some growth seen on CSF culture, and the staining has proved to be positive for gram-positive, which are branching. Stop at this point and ask from the fellows what can be the gram-positive rods. Like briefly, how do we
Could be
classify it?
could be nocardia. Branching rods could be also Corynebacterium, Rhodococcus, and actinomyces.
Anyone else? This was right. Anyone else? And considering his hospital exposure,
Gram-positive rod that can cause contamination. This is a clue. I think Rhodococcus is not a rod.
it's very similar.
Sometimes.
To look alike. This is a very simplified version of what gram-positive rods can be. They can be branching or non-branching. So in the branching ones, we think of nocardia and actinomyces, and they are simply differentiated on the basis of nocardia being aerobic and actinomyces anaerobic. And nocardia is also acid-fast positive, while actinomyces is not picked up on it. So simply if they are picked up initially on the gram staining, we cannot differentiate, we have to do further tests. Among the non-branching ones, there's spore forming and non-spore forming. The non-spore forming category has Listeria, Lactobacillus, and Corynebacterium, and the spore formings has Bacillus species and Clostridium species. This is a very simplified diagram for gram-positive frauds. So a patient was clinically improved, headache had settled. What we did, we stopped the vancomycin since there was no gram-positive cocci at this time. Meropenem was continued, and we added cotrimoxazole.
Anyone why cotrimoxazole was added?
With the suspicion of nocardiosis.
That's There is a question in as well. Why ceftriaxone was stopped and meropenem started?
Okay, when ID was taken on board and we started on meropenem, but what's going through our mind was that patient had a recent surgery. He had also hospital exposure. So we wanted to cover the gram negatives broadly. We wanted to cover the anaerobe. We wanted to give anaerobic cover as well. Why? Because there was a collection, air containing collection, both in the brain and at the spinal level. So that was the rationale. And in addition, if you see, pneumococcal cover is also present in meropenem. So that was the rationale at that time.
Enterobacteriaceae and all extended cover.
I hope I answered it. Okay, so patient came in emergency on 6th of December with nausea and vomiting. And the electrolytes revealed hyperkalemia, potassium was 5.9 at that time. So we had to stop cotrimoxazole and add linezolid here. And the meropenem was continued. Then we received a lab alert on 10th of December. The CSF culture susceptibilities were made available to us, and they were susceptible to amikacin, imipenem, ceftriaxone, clarithromycin, cotrimoxazole, and linezolid. This was the pattern of susceptibility. So we called back the patient and discussed treatment option with him. There was issue of long-term IV access. He was not in favor of PICC insertion, and of course he was a shopkeeper, so he had affordability issues as well. So we had suspicion he might be losing further doses due to his affordability. So ceftriaxone was started at this point. So meropenem was basically switched to ceftriaxone, and we continued with the linezolid. After this treatment adjustment, there was another admission on 17th of December with headache. Headache has returned, but there was no other, no fever with it, and nausea and vomiting was present. So at this time, ceftriaxone and linezolid he was taking it, but we suspected poor compliance from the patient. Examination, he was widely stable and there were no signs of meningeal irritation. We performed a MRI with brain at this point. So if you can see, it almost looks okay in the first look. There is very subtle enhancement, but you cannot appreciate any collection, any abscess, anywhere, any other lesion. So at this point, there was no lip meningeal enhancement. The small enhancing area in the right cerebral hemisphere on the T1 and T2 we discussed with the radiologist, but it was not big enough to be appreciated. It was a very small area. And the small other area, the nodular enhancing area, right MCA, it had almost resolved, so it was also not visible. The CSF analysis done at this point was turbid. WBC is almost the same, 2,220 with predominant neutrophil, and glucose was 25. Next, let's make comparison. So the next slide is for comparison of both the CSF.
Both आगे चले.
Bilal, आप screen आवाज आके बैठ. So you can see the comparison. There's not much difference between the first 16 November and 17 December CSF, right? Cell count is almost the same, and it is predominant neutrophilic. Next slide. So at this point, ID is not board. That Zoom was stopped. We continued with the lensolit, and we since we had the sensitivity, so we added imipam. We started the patient with imipam. We did some more work of more history, but it was virus variant and anti-HIV was negative. The CSF culture done on 17 December came out to be negative. Patient improved after 48 hours, so he was discharged. He had a short follow-up on 31st of January. Patient had improved, it was asymptomatic. So by this time, he had completed 6 weeks of imipenem, and hence was stopped, and linezolid was continued. So there are 2 agents at this point. The third OPD visit was on 22nd of February. Patient had disturbing symptoms, severe stomatitis and glossitis. So we had to stop linezolid due to this reason. And since there was oral options were limited, we added 4-thymoxazole in low dose here for the established.
Sorry to interrupt, but we here from AQH wanted to see the sensitivity report of nocardia, the culture again, if you could.
So this report we received from the Aga Khan lab. The sensitivities were done there. Can I move forward? Should I move forward?
Now we can see that.
Okay. There was a question that what was the possible source of nocardia? Is it iatrogenic or patient was HIV? What was the status of HIV? So that was checked, at which was negative. And another question, whether there was any lung involvement. Chest X-ray probably not shown here, but that was completely fine.
He had no respiratory symptom and chest X-ray was okay. Second OPD visit हमने discuss करी 6 week MMIDSP की continue. So he came back on 22nd of February with severe stomatitis and bursitis, due to which we had to stop Lanzolid. And we added protramoxazole in lower dose here and strictly advised the patient for serum potassium monitoring initially twice a week and update us. So patient remained well from February till the May. He came back to us on 22nd of May with headache from 1 week and neck pain for 1 week, but he had no fever and vomiting, and he was compliant with the treatment, the low dose protramoxazole. We performed CSF analysis, it was turbid, and if you can appreciate and remember the prior findings, the PLC count has 3,000. Neutrophilic, here 90% neutrophils, glucose is 42 and protein 230. So comparison of the first, second, and third. You can appreciate the cell count has progressively increased, and it is predominant neutrophilic till this point. MRI brain with contrast was again done, which is grossly normal. It had no leptomeningeal enhancement. We again discussed the patient with neurosurgery, and they advised to continue with conservative management. So imipenem was added, amikacin. So we went on with triple regime here. Imipenem, amikacin, and cotrimoxazole, since he was tolerating well and there was no hyperkalemia, so it was the dose was increased. If came for follow-up on 3rd June 2025, hyperkalemia was again there with nausea and vomiting, so we had to stop cotrimoxazole. Imipenem and amikacin was continued, and we switched the oral protramoxazole to Lanzolid. On the follow-up visit, patient clinically improved. There was marked improvement, and awaited cultures came out to be negative, bacterial, fungal, and AFP as well. From the 27th May, this was the prior cultures. We performed a lumbar puncture again, which showed for the first time lumbar puncture. So for the first time, it showed improvement. You can appreciate the cell count till May was rising with predominant neutrophil, but the one we repeated now, it had only 38 and 60% neutrophilic. And the patient had improved as well. So by this time, he had completed 8 weeks of imipenem and amikacin, so it was stopped, and we decreased the dose of Lanzolid, stepped it down, and continued it. The recent follow-up was on 2nd of August. Patient was completely okay, clinically improved. A neurosurgery advised to look for the lumbar spine area, so it was performed. There was no pneumocephalus and no residual collection. So for now, we plan to continue this Lanzolid on a lower dose. We have advised the patient follow after 2 months. So you can see the post-surgical changes are there, but there is no collection or the air, prior air, the lack of air is not there. It had resolved. The hospital. So this is the hospital course. I will quickly summarize it. The first visit was on 16th of November. In the ER, he was empirically started on ceftriaxone and vancomycin, but when ID was taken on board on 18th of November, we switched to meropenem and vancomycin. The rationale I just explained. We received microbiological alert on 26th of November for the gram-positive branching cause. So the meropenem was continued and we added cotrimoxazole. We stopped vancomycin at this level, no evidence of gram-positive cocci. He developed hyperkalemia with the cotrimoxazole on 6 December and presented in emergency, so we had to stop it and switch it to lenalidomide. Meanwhile, the meropenem was continued. So he developed his first relapse while on this regime. He was 10th of December. The CSF cultures, the verified report we received from Afan was on 10th of December. Patient had avoidability issues, so meropenem was switched to ceftriaxone and lanzolid continued. He was a second time admitted from 17 to 19 of December. At this time, we stopped the ceftriaxone and added imipenem with lanzolid. We stepped down to lanzolid only when 6 weeks of imipenem were completed on 31st of January. While patient was on lanzolid, he developed stomatitis and glossitis, so we had to stop lanzolid on 22nd of February and we switched to cotrimoxazole, low dose. He remained well for quite 3 or 4 months and presented to us with again with headache. So on the second relapse, we went on with triple agent, imipenem, amikacin, and cotrimoxazole, and we completed 8 weeks of imipenem and amikacin, and cotrimoxazole was stopped due to hyperkalemia again. Its dose was increased on this admission, so we had to switch it to lanzolid. The first CSF clearance we achieved was on 14th of July. So a point to be noted is after treating it with triple therapy. So 14th of July till now, patient is on low dose maintenance lanzolid, tolerating it well and clinically improved. So our case is finished till now. Pretty long. Anyone has to say anything at this point? Okay.
So I have one question. Why he was put on linezolid maintenance therapy? He wasn't immunocompromised, and what I believe this nocardia was likely acquired during the surgery or could be the iatrogenic cause.
Patient doesn't want it to be on IV therapy. There was IV excess issue, and we suspected that he maybe he had missed 1 or 2 doses, and he might miss future doses as well. Secondly, he did not tolerate the cotrimoxazole, so we had limited oral option, and that's why we shifted the patient to oral linezolid.
The treatment duration of CNS neocardiosis is actually 12 months now. She's asking about maintenance. Why you are now giving linezolid? इनका question ये. So the treatment duration for CNS neocardiosis is 12 months. That is initial 6 to 8 months of injectable followed by oral.
So I think let's discuss this nocardiosis first and then we'll take questions. That would be better.
Okay. So till now, more than 80 species have been identified in humans. The common ones are Nocardia nova, Nocardia farsina, Syria, Georgica, abscessus, and brasilensis. These are the most common ones. It's a branching filamentous gram-positive rod, partially acid-fast, catalase positive, aerobic, unlike the anaerobic actinomyces, and it is written in literature. 33 out of the 80 species can cause human disease. Most common are with steroids and nova.
Next. Next.
So it is widely spread in our surroundings, in the decaying soil, in the aquatic environment, both in the clean and dirty water areas. It is inoculated into the human body by primarily two sources, by the skin root or through inhalation. So skin root can be from the scratch from the animals, and inhalation route can be for example, there have been case reports of multiple outbreaks in hospital settings, and the post-surgical patient, post-cosmetic procedure patient. So they have been seen the construction areas. They can that can be one cause of spread, and it can also spread via the fomites, the touching of objects that can then lead to infection. Mostly it presents in the immunocompromised individuals, those on steroids, solid organ transplant or malignancy patient, hematological, HIV infection, immune deficiencies, healthcare outbreaks I just discussed. Miscellaneous causes, those who are diabetic, uncontrolled, having respiratory tract diseases. There have been a case report with concomitant mycobacterial infection. Those on T cell inhibitors and TNF alpha inhibitors, they are more prone. Predominant site is the pulmonary, but CNS and cutaneous are also there. So the pulmonary endocarditis can present in a variable ways. It can present with consolidation, with nodular lung lesion, and the C number picture towards the right, it shows the empyema has progressed to empyema necessitans. It can present with cavitation and pleural thickening as well. So it's a variable presentation. In this is the T1 with contrast. In T2, you can appreciate the multiple brain abscesses with surrounding brain edema. The cutaneous cardiosis can present with superficial skin infection, abscesses, ulcers, and it can also present with lymphocutaneous, the one with the hands on the left side, and it can present with mycetoma. This is the rare and less common presentation, but rarely it can present with the bone prostatic infection and very rarely bacteria. So the best specimens for diagnostic purposes in the literature so far are respiratory secretions on top, then the skin biopsies, and then aspirates from the deep collection. It can be gram stained, and further it is identified on modified acid fast stain. The culture media usually takes weeks, but it can be identified in 48 to 72 hours. Blood agar, the chocolate agar, and Conti's agar. And for species identification, mostly done in our setup with the Malika. And drug susceptibilities are identified on PMB, the broad microdilution method. So for imaging, it is best to perform MRI brain for cerebral and CT scan chest, and we have discussed what patterns we can see. So we have taken this this short article to look into the local data. This was from Al-Khan Peeps, Antimicrobial Susceptibility and Clinical Characteristics of Nocardia. This was the data was taken from 2014 to 2016 and published in 2018. 52 isolates were taken. It was mostly from the pulmonary samples. So it was seen. Next slide. Seeing the sensitivity and resistance pattern, you can see in this graph. So all of the 52, they were sensitive to linezolid. 49 were sensitive to amikacin, 47 to cotrimoxazole, and 20 to imipenem. And there was resistance was seen among amoxicillin, ciprofloxacin, and clarithromycin. So it was 100% susceptible for linezolid, then amikacin, then cotrimoxazole. This was some of our local data. So the primary treatment regime for brain abscess or pneumonia, the backbone is cotrimoxazole, 15 mg per kg per day in divided doses, and it has to be given with imipenem and cilastatin. For skin lesion lymphadenitis, cotrimoxazole alone is enough. Alternate regime also exists. For brain abscess, there is no response to initial. We can continue with linezolid and meropenem for 3 to 6 weeks and prolonged in case of immunocompromised patient. And then we have to switch to cotrimoxazole prolonged low dose therapy as maintenance. Maintenance has to be kept for 12 months. Pneumonia, in case of pneumonia, imipenem with amikacin, and this is the initiation, and we follow it with cotrimoxazole maintenance. In skin infection, some literature suggests also minocycline use, but some do not suggest it. Only monotherapy with single agent is enough. So the treatment duration, skin infection is 3 to 6 months. For lung consolidation is 6 to 12 months. For brain abscess is 12 months. Disseminated infection also 12 months. This table we have taken from American Society of Transplantation, and the last line is from the tabulated upper part, you can see the backbone of empiric therapy is cotrimoxazole in all of the regimes. And prolonged treatment, duration of treatment is mentioned 6 to 12 months. The last line is the point I wanted to focus. For severe and life-threatening diseases, we have to consider the use of 3 agents, triple agent, imipenem, amikacin, ceftriaxone or linezolid with cotrimoxazole while awaiting susceptibilities. So just briefly and quickly, we'll go through the literature review. This first case literature, we have listed here only the neurosurgical cases with nocardia. So this first case is both neurosurgical nocardia meningoventriculitis. This is from 2023 New Microbiologica journal, and it is of a 47-year-old female patient. She was immunocompetent. She underwent third ventriculostomy and left retrosigmoid craniotomy for schwannoma. And post-procedure, patient developed signs of meningitis, the neck stiffness, and headache 1 week later. She had a prolonged hospital stay, and initial cultures were negative, the lumbar punctures cultures. So eventually, after 31 days of hospital stay, the endoventricular CSF sample was drawn, which grew nocardia seneca. She responded to imipenem, cotrimoxazole, and she was discharged on linezolid, and amoxicillin was continued for 12 months, and the patient survived. The second article is meningitis and spondylolisthesis in an immunocompetent patient. So this patient was a 52-year-old male. He had a diagnosis of lumbar spinal canal stenosis from 1 year and had multiple steroid periradical infiltration. The most recent was 1 month back. Post this procedure, the recent procedure, he developed left frontal headache, nausea, and the sign of meningitis. He was diagnosed on MRI. The multiple small abscesses were seen, and CSF culture grew nocardia nova in this patient. He responded to imipenem amikacin and later switched to maintenance cotrimoxazole. This patient also survived. The third case is of multi-drug resistant nocardia caused with cervical spine osteomyelitis in immunocompetent patient. So this particular patient had a lumbar osteomyelitis at L4 and L5 requiring laminectomy. She presented with neck pain and right arm stiffness. So it was diagnosed on MRI spine at the level of C4, C5 and underwent dissectomy, washout and bone culture. And on this culture, she was, the intraoperative culture, it was identified as nocardia nova. So it is the second case of nocardia nova. This patient responded to amikacin and cotrimoxazole, long-term maintenance, she survived. Okay, we have one article, the last one, nocardia with co-infection. So this was a rare case of multiple brain abscesses caused by nocardia abscesses. And this patient had a co-infection with tuberculous meningitis. He had no prior, he was immunocompetent, no prior comorbidities. He had a 1 week history of fever and headache, predominantly in the bilateral frontal region. CT chest had bilateral pneumonia and CT brain had multiple abscesses. So the resection of the deep lesion, and he was placed ventriculostomy for external drainage, and this drainage samples came positive to be gene expert for MTB positive, and the culture grew nocardia abscesses. He was given ATT with cotrimoxazole, imipenem, and linezolid, and steroids as well. But by day 10, his condition worsened. He went into septic shock, and this patient died. So now we'll take question and we'll start the discussion. What do you think, if anyone want to discuss and give their input, what went wrong in our case, why there was a relapse? Anyone, please?
Comments from fellows? What possibly went wrong?
We think that from the beginning, the regimen should be triple drug regimen.
Yes. And any other possibility? So this was the first thing probably went wrong. Any other thing?
So what we have seen, discussed retrospectively, there was poor treatment response. Initial monotherapy was maybe insufficient. The dual therapy later switch was maybe also insufficient. Late switch to the first line agents can also be one of the reasons. We changed the antibiotic, so there might be in vivo resistance from the organism. About undiagnosed immunosuppression, the history taken multiple times was not suggestive, and HIV testing was negative as well. So there was no immunosuppression evidence till now in the patient. Why did the patient relapse? There might be extensive disease burden, but one question comes to our mind, but we were on board with the radiologist every time the imaging was done. and there was no abscess in the brain, and the spinal level small collection also resolved on the follow-up. So, and there was no active discharge as well. There can be a reason of micro CSF leak. Yes, that possibility exists, which had caused the pneumocapillus and the air in the brain. This might be a reason for recurrent infection, but not till now. The neurosurgeons are not of this view. There's no evidence till now. Iris-like reaction, we search for literature, but I could not find any particular article on this. So that's this possibility from all. This is all learning from this case, and I would appreciate if anyone gives their input as well. Consider triple agents in extensive disease burden, poor treatment response, and in case of disseminated disease, in this case, 2 areas were involved. In case of immunocompromise, again, we start with the triple agent. In case of poor treatment response, we have to rule out any unbrained abscess which went unnoticed previously, rule out immunosuppression, any anatomic defects, and also co-infection, because there's data over co-infection as well. But in our scenario, it was all the cultures, fungal, AFP, they were all negative.
Questions?
Yes, sir, I have a question. Sir, was it a relapse or what was it was a poor clearance of the initial infection? Because I don't think so that initial culture जो था वो clear हुआ था due to poor antibiotic selection or likely immunotherapy. तो culture clear हुआ. December to be culture.
Multiple cultures were done. They were negative. Only first culture was positive. So that's why we call it relapse, not recurrence. Relapse is you're treating and the disease comes again. I think in recurrence you treat it fully and then it recurs. That's why we are making it probable relapse. We don't know exactly the reason why this patient behaved so poorly, being immunocompetent. Why the behavior was just like an immunocompromised patient.
Yes, sir, but for the CT scan of the chest, as we know, a patient has the cerebral nocardiopathy, we must rule out pulmonary manifestation as well. It was
We had no pulmonary issues, and the chest X-ray. I'm sorry.
Actually, it's vice versa. If you have pulmonary nocardia, then always get the CNS imaging because CNS duration is prolonged in CNS nocardia.
And one more thing, a radiologist told that during the dorsal spine CT scan, there are slices of the chest. They couldn't find anything over there.
Assalamu alaikum. I have one question. I am Dr. Kashif from Peshawar Nurses Hospital. In routine care, we see patients with these neurosurgical procedures and these FCCs and meningitis. So, are we going to look for some specific clinical clues to send modified ZN for processing to the lab, or but because it is so rare, should we send it on everyone, or we should keep in mind that if these clues are there, or these clinical parameters are there, then we should send the modified ZN, because we see many cases who present like this and maybe never diagnosed. Should we make it a routine to send these modified ZN on specimens in neurosurgical or other surgical procedure, or there should be some clinical clues or parameters that now we are interested in nocardiosis?
So our microbiologists were on board and they informed us that even in our case, the direct sample was negative for gram stain. So probably if there is a high index of suspicion, you can request it. But I am sure other microbiologists can comment upon it. Even in our case, it was only seen only after when the colonies started growing on the culture plate. So if the patient is immunocompromised, transplant patient, you're high risk, and you feel like there are risk factors and the disease is disseminated, probably you should request this thing, a modified acid fast strain as well, along with CSF strains.
Jazakallah, thank you. But the question here is that this patient was immunocompetent. He underwent a routine neurosurgery. He has no risk factors. So that's what my question is, that in a immunocompetent patient, what should be our protocol of looking for nocardiosis?
Again, I think it's a judgmental call. In immunocompetent, we usually don't think it's a
Can
rare thing.
can I respond to this? Dr. Juberia here from AKU Microbiology.
Yes, definitely.
Okay. So you know what we've started doing now, because when we receive a brain abscess, when we identify the sample as a brain abscess or anything, a pus collected from the intracranial cavity, we have started performing, not only do we do a gram stain, we do a KOH and we do a partial acid fast by default. Because it's too precious a sample and we don't want to miss anything. And even if we don't know any history, but we just know that it is from the intracranial cavity, whether it is subglial, it is subdural, it is epidural, whatever, or intracranial, as in parenchymal. So we just by default we have started performing these three stains for smears, so that we don't miss anything.
This is good practice probably.
So,
Yes.
so I'm Dr. Zishan from Khan Hospital. So another thing I want to add is that if we have a sample from a brain abscess with so much pus, there is always a possibility. So we have to make a good quality of gram stain. This is very important, and we have to review very thoroughly. Probably we can make one or two or more than 2 slides to review any possible pathogens. I think it's also very important to have a good quality of gram smear.
Well, in our case, it was CSF. Probably the sample is not so much sufficient. And
Actually, CSF sample was received in lab. So, but we know the situation of CSF RE. We performed gram stain. On gram stain, we couldn't find anything. But once the growth appeared, we informed clinical side that they are gram positive rod is branching and we're suspecting nocardia and we're doing modified method on it. Later on, we informed that it is nocardia and we sent this for the susceptibility testing. But this was a bit unusual that the sample was CSF, wasn't brain abscess. Otherwise, on brain abscess, obviously, you suspect nocardia.
So probably on our side, even microbiologists think of nocardia and they do modified abscess samples. Any other questions, comments?
I'm Dr. Satya from same Infectious Diseases Hospital. I would like to add one thing, that a very close clinical collaboration between the microbiology lab and the clinicians can be good, because in suspicious cases, when we don't see on the initial microscopy, we can increase the incubation period and for such suspicious organisms.
Thank you. Any comments on this? There was a question that was it sensitive to meropenem or only imipenem? So the culture from our Khan reports imipenem, I think only.
Imipenem has a broader coverage for gram positive. So this was a gram positive branching rod, as compared to meropenem has more coverage for gram negatives.
Okay. So it's written that you can use meropenem as an alternative to, CNS nocardiosis if you are not going to use imipenem. I don't know about the sensitivity of meropenem directly with nocardiosis. Are we doing it?
No, we're not. And we don't have any breakpoints for it.
Okay. I think that's all. If any comments, otherwise we can finish. What was the possible source of this nocardia? You can't see. Number structure must be varied. Next, you may not be the trigger. It was 600 once a day. Because he developed, there's a question, what was the low dose of linezolid? It was 600 once a day because he earlier developed severe stomatitis and oral erosions with the standard dose of linezolid. Just for the discussion, what is the total cost of care till now? Was he operated at a government? No, he was, totally managed in a private setup here in Shifa.
So,
Yes.
sorry.
Yes, Dr.
Other than that, please also discuss how did, pneumocephalus kaise hua tha? I mean, where did the gas come from?
We discussed this with microbiology. Is there any infection causing gas forming?
No, it's
any
yeah, I'm really concerned because nocardia doesn't usually form gas, and I'm worried that there might have been something else as well, which
Yes, we that's why we kept on involving neurosurgery because we were thinking that it was an iatrogenic, injury at the spinal end when earlier the surgery was performed, leading to air formation, a CSF rent, and then ascending, infection in the meninges along with air. And it actually gradually resolved.
Right.
I don't know whether it was self-absorbed or treatment showed some response.
Sorry, my apologies for interrupting, but you can carry on with the public health implications.
And couldn't understand the question. Is it for us?
You were discussing Dr. Amjad Mahboob's comment on cost of care and.
Yes. Okay, I think that's it. Thank you very much, everyone, for joining ID CPC. Let's conclude.